It looks like folks have kind of trickled in, and the waiting room entry process has slowed down a little bit. So we're going to go ahead and get started. And if people join us, they can join us. My name is Kelly Firesheets, and I am with Cordata. And I'm really excited today to have what we hope is really a kind of informal conversation with some of our colleagues in the field about just kind of their deflection programs. So we want to talk to deflection programs, and we've kind of intentionally picked people who are at different stages of their programs. We got a really new program. We've got some folks who are more experienced, and kind of learn where they started, how their work has grown over the years, and what they've learned in the process. I know we have a lot of folks on the call from our partners in West Virginia and our partners across Ohio, and you guys have great experience with this also. So I'm hoping that you'll jump in the chat and ask questions or make comments and kind of participate in this as a dialogue as well. And we'll definitely make sure we have some room at the end for conversation. So this is so informal a webinar. We don't even have PowerPoint slides, right? We're not gonna like put any bullet points up on the screen or anything like that. I think there's a lot of shared knowledge we can have when we just take some time and sit together and have conversations. So that's the agenda today. I want to introduce you to three of my colleagues, and I'm going to let them introduce themselves. Actually, I'd like to start with Travis. Travis, can we start with you, and will you tell us just a little bit about who you are, what's your role, tell us about where you are and your community, and how long you've been working in the field.
Very good. Well, thanks for the opportunity. I appreciate it. So I'm Travis Karakoff. I work for the City of Harrisonburg Fire Department. I'm the Chief EMS Officer, and I manage our high threat response programs. So our SWAT medic program, our tox medics, fires of weapons, civil disturbance medics. And along with that, over time has also come our community relations and our community paramedic program. City of Harrisonburg, college city, second largest city on Interstate 81 in Virginia, about 2.5 hours south Washington, D.C. We're in the central Shenandoah Valley region. City population is about 76,000. We have James Madison University, that's an additional 42,000. We have two other small colleges that make up about additional 10,000 students in the region. So all hazards fire department. We work closely with our law enforcement colleagues. We have become really involved in the community in the past 5 years. If I had to talk about our community paramedic program, I would say that it's even before its infancy. We don't have anybody right now that is on the street that is dubbed a community paramedic. What we do have is multiple processes in place, and different things that we look at, and different stakeholders that we work with to provide community paramedicine. We do have a grant in with the Bureau of Justice Assistance for a community paramedic program, funding from that to springboard that over 3 years with the focus on mental health, substance use dependency, and recidivism. So we started with the community, and we've kind of worked along. The fire department chairs the Regional Safety Net Coalition, which is part of a collaborative effort where there's 35 different buckets of service or silos of service that come together to see how we can collaborate with each other and help to support each other's efforts and things like that. And that's been a huge step for us in gaining support. When we went to do our grant, we were able to provide, I think, 16 letters of support from the jail to the healthcare system to the crisis workers to human services, all over the place, even to include the state's Department of Medical Assistance program, saying that for the first time they would be interested to entertain a Medicaid reimbursement pilot with our program if we get the grant. So we're very early on in this, and we're leaning on a lot of other people with experience to help us along the way.
Thank you so much. That's great. It's fun to hear. Will, I'm going to have you go next, since there's a little bit of a theme here, I think.
Okay, sounds good. Thanks, Kelly. Good afternoon, everyone. I see a lot of familiar names popping up on the screen here, so it's good to at least somewhat see some of you again. I'm looking forward to hearing from you throughout the conversation today. But as introduced, my name is Will Mueller, Assistant Fire Chief with the Corrigan Township Fire Department. Corrigan Township, as many of you know or may not know, is a suburb located just northwest of Cincinnati. We're comprised of about 60,000 residents. And is classified one of the largest townships in the state of Ohio geographically anyway, or the largest geographically. So my role here within the fire department as assistant fire chief, I oversee our emergency medical services operations, our training division, and our community risk reduction division, which quick response team happens to fall under. All the community outreach falls under our community risk reduction programs. And so from a quick response team effort, we started we really started the process back in 2014, and through 9 months or so of implementation and planning, we finally got the program up and running in July of 2015, and have been up and running ever since. So from that perspective, as from a fire department perspective, we really view that as the paramedics role on that team as being a social services based community paramedic. And as Chief was talking about just a minute ago about community paramedicine. I mean, it's been the buzzword in EMS for a decade, if not more specifically in our area, the last 6-7 years. And so we've really tried to embed ourselves in these types of social services based programs, really trying to capitalize on some of the health safety nets that are set up in our area. So I think I'll stop there, Kelly, and we can move on, and we'll address more. I guess we'll talk more about the program here soon.
That sounds great. All right. And then last but not least, Tom, tell us a little bit about yourself.
Kelly, thank you. And thanks to Cordata for having us here. So I've been a police officer for over 30 years. I first got involved in QRT thanks to Will and then his boss, Dan Malloy, where we saw how much success they were having in Corrigan Township. And I replicated their program in Norwood, Ohio back in 2016. Had lots of success. So Norwood is a town of about 20,000 people. That I worked for at that police agency for 27 and a half years. And then in 2018, Hamilton County got a grant, a COPE grant then to start a full-time or to start a QRT team countywide. So for those folks, Cincinnati, there's about 820,000 people. So we started a 2-day a week. We did the East on one day and the West another day, QRT. Back in 2018, and then she's also on this call. I got to give a shout out to Megan Gosney, my partner in crime. We had just recently built a quick response team. We actually have 2 full-time teams. They do your traditional door knock, overdose follow-up, as well as they each have kind of priority responsibilities. Team 1, their priority responsibility is African-American outreach, because we've seen a huge increase in African-American overdoses and overdose deaths in Hamilton County. And then our Team 2, their priority outreach, proactive outreach, is in Price Hill. So it's been a lot of work. It was kind of interesting going from a 2-day-a-week program to a full-time 2-team program. So it's been really interesting, but it's been, we've had lots and lots of successes. So thank you.
That's definitely something I'm going to ask you more about, Tom, while we talk today, is kind of about that jump from being a 1-day-a-week or 2-day-a-week program to like a full-on, full-time initiative, because it's a pretty big shift in a lot of ways. So, I kind of want to start with you guys at the beginning. I always like to frame these conversations in the why, because I think sometimes it's easy to jump to business and kind of gloss over what got us here and kind of why we got into this. So I'd like to hear a little bit about the 3 of you, and you can kind of go as you choose. I won't call any of you out first necessarily, but what sent you down this path? Like, this is doing things a little bit differently, whether you're in EMS or law enforcement. What was it that that started this for you? What made you want to start kind of doing things differently or start these kind of programs? What's your why?
I'll jump in there, Kelly. And so I think, first and foremost, the situation really dictated that we think differently and do things a little bit differently. As Director Fallon had mentioned, we had kind of started having conversations here in Coleraine in 2014 about what the true scope of the opiate epidemic was. I'm not going to get into numbers and statistics because we all know it's bad. So we don't really need to talk about that. But if you're asking about the why, then Public Safety Director Dan Malloy and myself were invited to a couple of discussions just to have conversations about what the true scope was, why we were in this epidemic, some of the main causes. And as we started to realize what the main causes were, we started to realize that we had a hand in that. And so we developed the philosophy here within Corraine's Fire Department that if we have a responsibility to respond to it, we have a responsibility to stop it from happening in the first place. And so if we look at the fire service in general, the fire service is built upon prevention and education. Fire codes came about because too many people were dying in fires. So we developed a very robust code enforcement system, education system that's built upon the framework of prevention. And so why are we not doing the same then for EMS, right? And especially such a problem like the opiate epidemic. So that was really the why. We really wanted to get into the business of being more proactive instead of reactive, because we realized that the reactive nature of what we were doing for the past 20 years wasn't effective. So we needed to do something different. And so that was kind of the catalyst, I guess, if you will, for starting to think a little bit differently.
That's kind of an interesting take on it. If we're responding to it, we should also be preventing it. That's a cool way to think about it.
Kelly,
Yeah,
I'll just. Who do you want to go?
I go for it, Travis.
No, I was just going to kind of jump in there and kind of shore the chief up with saying that he's absolutely correct. And I think that as time goes on, public safety, whether you're involved in law enforcement or you're involved in fire and EMS, and quite honestly, if even the human services part, we used to travel in very strict lanes, and there used to not be any fade over, not a lot of, kind of rally and support for each other, collaboration. And I think as time goes on, when we end up with conversations where there's multiple services around the table, we realize that we can augment each other and we can help each other and work through that. One of the things that, a lot of people will kind of lean on is things like social determinants for healthcare and things, which really is kind of a macro term. It involves a lot of things that we don't really have any control over. And we want to whittle down to the things that are individually changeable with people. And in public safety, it doesn't get any more direct point of service than a police officer working face to face with someone that they know what their specific challenges are. And the same thing with the fire department responding to medical calls. And we know these people in the community. And because we know them, we sort of develop some health informatics about those individuals. And then based on networks that we have and resources that we have, we can not necessarily fix it for them, but we can point them in the right direction or get some assistance their way. And I think this is absolutely right that the chief mentioned community risk reduction. NFPA 1300 is the standard for that. And based on what we've done with the numbers of fire deaths in the United States and property loss and things, we can couple kind of some of that into a plan for community risk reduction for things like opioids and falls, some chronic disease management and things like that. So this sort of fits right in. But I think over time, as we evolve, we really there becomes some overlap. We see a lot of co-response models now and things like that. We even bring peer support specialists, people who have lived this challenge, in to help us. And I think it just demonstrates that we're looking for a solution. He's absolutely right. Responding to it after the fact does nothing on the front end to try to change it.
Tom, how about you?
So I guess I should talk about my other role, that I oversee the heroin task force. So we investigate overdose deaths in Hamilton County, and we've done over 1,200 since 2015. So we were in that role, we're holding drug dealers accountable for selling drugs that are killing people. So there's no better way to complement that than reaching out to those struggling with addiction and try to get them connected to treatment. So that's what we're doing on the QRT. And then just in our recent, so we now have the proactive and the reactive QRT, which, instead of just going after people that have overdosed, now we want to proactively find those in hotspot communities and in specific neighborhoods to reach out to them before they even overdose. So we're trying to take, our opiate epidemic that everybody's struggling with and take it to the next level, not just holding drug dealers accountable, not just reaching out to those that have overdosed, but also those in the high overdose neighborhoods and those demographics. So that's kind of really interesting, but kind of difficult to set up.
So one of the things that strikes me about this is that you didn't just make a program like, okay, here is our program. We're going to make our program and do our program. And now we've done this. It sounds like all three of you has been kind of an evolving process where you started kind of doing one thing differently, and then it grew a little bit more, and then it expanded a little bit more. It's kind of an evolution of your work in a lot of ways. Does that sound accurate?
Yeah, absolutely. And I will also tell you that if you've only seen one of these programs, then you've only seen one of them. And the nice thing is they're very germane to what the needs are in a particular community, right? So some communities really struggle, and we've seen communities ruined by opioid crisis. And there's some communities that's not a problem, but what's a problem with them is maybe some chronic disease management and things like that. So when you see these kind of programs kind of develop and evolve, and you see missions change and missions expand, I think that is in response to the program being community centric, and it's focused on what the specific needs of that community are, because they certainly vary geographically depending on where you're at for a variety of reasons.
So I'm curious to hear from you guys a little bit. Let's go back to the beginning, like the very beginning, kind of when you first started. I'm going to say when you first started your program, even though we both talked about how kind of it's not necessarily that clear, but back to the very beginning, and things got started. Tell us what was that like? Right? What did you do? Who did you need to have at the table? Did you have funding? Tell us what the experience of that was like.
All right, Kelly, I'll go first on that one there. We had no idea what we were doing. So we'll just start there, right? We had no idea what we were doing. And, we were very blessed to be able to be put in the path of a lot of great people. First and foremost, we weren't afraid to fail. We weren't afraid to jump outside of our traditional roles. We weren't afraid to extend ourselves beyond our comfort zone and start having conversations with people we've never had before. We had to learn a lot. So it really started with education, having conversations. And that's really what we realized then, that, the biggest problem facing us was that there was just such a lack of connectedness to resources. So that's how the quick response team concept was kind of developed. It was developed around removing barriers to treatment. We had no idea that it was so difficult to get connected to treatment. We had no idea that you couldn't just call an 800 number and get into treatment later that day. That's what the community believes. That's what our culture believes. And so as we learned that, it was very eye-opening. And so we were able to develop then a program that was trying to eliminate as many barriers as we could, bringing recovery resources directly to the doorstep, taking stigma, taking transportation, taking time of day, taking all those things out of the equation for those who are trying to get help. Lack of identification, lack of connection to public safety nets like Medicaid. And so we had no idea. So that's kind of what started, and that's kind of what it was like. I mean, I don't know, it's kind of hard to describe when you're breaking out into a new world where there's no model for you to replicate. You're just going along kind of day to day. It was an exciting time, I will say that. I know, Dan Malloy and I didn't go a day without talking about the program, how we were going to do things better. So that's, I think I'll kind of turn it over to the other two, but for us, it was, just not knowing a whole lot about what we were doing. So.
Kelly, I'll just follow up with Will on that. We were able to learn a lot from them. And there's somebody on this call that was really instrumental, and that's Nan Franks that Dan Malloy introduced me to. And the one thing, the people that do the QRT, you learn so much from people like that, from their backgrounds and their experiences that us as police and fire don't understand. And, what we've been able to do, which started back in 2014 with what Coleraine started, is we don't have trouble getting people into treatment now. We've been able to win that. And one of the things that I know when we had breakfast last week, Kelly, we were talking about with our friends was, that what's really cool about QRT is you can make it fit your needs. There's not if people have tried to institute other deflection models, they're pretty rigid. And with QRT, it's not rigid. Whatever your needs are, your community, which may not be overdose, which may be other forms, you can make that fit. So just learning from your partners was huge. The throwing in the peer coaches was huge, which taught our QRT people so much more too. That was another big advancement in this game.
Yeah, I guess I'll jump in there, and I have to echo the same. I guess I look back when we got involved, and I remember the very first person that we helped that kind of created a chain reaction of more questions than answers about services that are available to people and barriers and things that limit them. Had a gentleman that's homeless, and he was going to the emergency room 3 or 4 times a week by ambulance because he needed to charge his chair up. And they quickly reached out to us to tell us to stop bringing him there. So the long story short is we started talking to some of the guys in the firehouse about this gentleman. And one of the firefighters said, well, why don't we, he's like, I got a solar charger that I use at my camper. Why don't we put a solar charger on his electric wheelchair? And during the day when he's out, it'll charge. We done that. And then what happened was we resolved that for him. And then the healthcare system started reaching out with a bunch of other challenges, a wide variety of them of different types. And a lot of these folks that we interact with, they're not just, their problem or their challenge is not just singular, it's a myriad of things. And what we began to learn is that there were resources there, but they weren't easy to connect to. And the other thing is, about the time you think you've got all of the community resources figures out, somebody will mention another one that you've never heard of before. And that's where we got involved heavily with the Safety Net Coalition regionally, and got our name out there and got our interest out there to see how we can connect people with service, because we see a lot of people daily that are service consumers. They need that service, and they trust us. I think it's undisputable that somebody with the fire department gear on can walk into someone's house and ask to look through their medicine cabinet for them, and they're going to let them do it when they won't let a lot of other people. They won't let maintenance do it. They won't let other public services do it or anything like that. So the public's got a lot of trust in us, therefore they're counting on us. And we felt like that we needed to be at the table for every discussion of how we can work to be part of a solution for them.
I think that's interesting. It's just kind of creative problem solving sometimes, that people, sometimes the needs people have may be actually relatively simple if you can get enough distance and think, oh, hey, let's figure out how to help this guy get a solar panel to charge. That's a really cool example. Not always so simple probably, but that's a nice one. I have a text from Tom Fallon, and he's having camera problems, but he's still here. Tom says he can hear us. Is that right, Tom? Uh-oh. I think we just lost him. Well, hopefully he'll get back in. I'll keep an eye on my phone. Hopefully he'll be able to get back in, but we'll kind of go on. So, so one of the themes I'm hearing here is understanding the needs of your community and being responsive to the needs of community, as opposed to trying to hold to a specific program or process or expectation of what you're doing. Is that fair?
Yeah, I think that's exactly fair. And I think the other thing, a lesson that I learned is I kind of started with viewing success as what I think it is, what it looks like to me. And quickly found out from some of our human services folks that success doesn't look the same universally, that maybe if you can decrease someone's incidence of whatever by 50%, that's success for them, or allowing the person that you're helping to identify what success feels like for them. We work with a lot of homeless folks to try to get them housing and things like that. There's a remarkable number of them. They don't want housing. They've made the decision, to live in the urban jungle. That's where they want to live at. But success to them means that, they've got a food source regularly. So if we can connect them with that, then in their eyes, that's success. And what we've had to learn is that we need to champion that as a success, as a win. And it might not be how we view it as a win.
You gave me just the perfect entry to ask my favorite question of all questions, which is exactly what you just said. How do you think about success here? Like, what is success for the people you're serving, and what's success for your program overall? So if a success looks different for each person, Travis, how do you know if what you're doing is working?
Well, I think what we do is we allow that person, number one, to attest to that, that they can speak to that, and there's some sort of data that indicates that that's a success. If it just means that they're making their weekly support group meetings, and the support group reports back that their attendance over the last 90 days has been 100%. Then that's a win. And I think a lot of times we and this is tough, particularly in the emergency services sector, is we look at a lot of data based on things that are kind of universally recognized: response times, scene times, cardiac arrest saves, things like that. But when you get down to, and again, I go back to even getting below social determinants, where we look at individual needs. Well, with individual needs are going to come individual successes. And I think you have to be creative in how you present those. And it's not just as easy as coming up with a spreadsheet of showing, that you've reduced response times or whatever the case is, but you have to present some cases, and you have to let some of the data kind of speak for itself.
Tom and Will, what's been your experience with that?
Well, Kelly, I think Will gets credit for this. We share it, but in 2020, overdoses were up everywhere. Significant percentages in Hamilton County. We saw a 11 to 12% decrease in overdose deaths last year. So I think our creative use of QRT and other programs and naloxone distribution and fentanyl test strips and all the different things that we're doing, hopefully we'll still see those numbers again this year. But when you see 90-some thousand people dying across the country, and we see a reduction, and it's pretty huge. So I would say that is part of it. And we are open in Hamilton County to a lot more of the deflection programs, and hopefully we can get more in place moving forward.
I would say, we have performance metrics. We follow them. We look for them. We put them into plug our numbers into a dashboard every month. And so I will, in addition to what's been already said, this is one thing I've learned, and Tom Fallon gave Nan Franks credit earlier, and I didn't realize she was on the call. But I'm glad she is. I'm glad she's going to hear this, because she taught us that this is all about relationship. And when we talk about the secret ingredient to success of a QRT, it's got to be relationship. So the way that I kind of view our success here is one interaction at a time and developing one relationship at a time. So success occurs at the relationship level. If we achieve relationship, we've achieved the success. Then the numbers will happen, but they won't happen without that relationship first. So we need to develop the trust and the respect in the community, to be able to work to get into the doors, to get to the doorsteps of these individuals, more or less get inside their homes, or to get them to talk about their problem, and then be willing to jump on board what these three individuals from the quick response team are saying. That's not going to happen without the trust and respect that develops in relationships. So success to us here is relationship.
Okay, so Will and I've known each other long enough. Just for people I don't know, I've known Will for a long time, so I can say this like pretty bluntly to him. Will, the human in me loves this, and the psychologist in me is like, yes, Will. But the researcher and evaluator in me is appalled. So because I love data and I really want to understand what's happening, right? And see numbers that show me what's happening. And I see this whole call of people. We got a lot of people here who may be trying to figure out how to do this. And I think, well, we got to have a little more structure than that, right? So how do you deal with people like me? How do you deal with the numbers people? And what are the right ways to measure this kind of success?
Well, so there's this mute button.
Oh,
no, and you bring up a great point. And so, and I guess, we talk about data, we talk about number of connections, we talk about the number of, face-to-face communications that we have. And so we do track numbers, we do look at numbers, and certainly that drives the quantitative analysis that's necessary to demonstrate success for funding purposes, right? Because I can't stand in front of a board who's going to fund our program and say, hey, we love making friends. That's not going to drive our funding. So, but certainly we look at those metrics. We look at our number of overdoses. We look at our face-to-face communications. We look at the number of those individuals that we actually made face-to-face communication with. How many of those did we get into treatment? How many Narcan kits did we distribute? How many fentanyl test strips did we give out? All those things are just, there's not one magic bullet. We know this. There's not one magic conversation. It's a bunch of little things that all come together. It's a bunch of little tiny pieces to this huge puzzle that we can't even comprehend the final picture. But what we're doing is throwing all these little pieces to the puzzle at it. And here's another measure of success. One of our paramedics was off duty at a local grocery store, and an individual came up to him and said, hey, Doug. And the paramedic looked at him and recognized that he was one of our QRT clients from about 3 years ago. And this QRT client recognized Doug as being one of our paramedics on our quick response team. And he goes, hey, I saw you from across the aisle. I just had to come up and say, hey, and I had to thank you. And he goes, do you remember me? And Doug's like, oh yeah, I remember you. You were one of our toughest clients. And he was one of our toughest clients ever. And he goes, well, I've been clean for 3 years. I'm getting married. I'm getting back in school. And so how do you define that? Like, how do you quantify that? It's even hard to qualify that, right? So those are the wins that we look for. It is always hard measuring prevention and showing what you stop from happening, but there's just so many different angles to look at it and look at how the success drives your program. I hope that kind of clarifies and answers your question.
Tom, Travis, do you guys have anything along those lines?
Yeah, Kelly, I'll just add when we first started, we all focused on connection, referral to treatment. And that was really the key. Are we getting people into treatment and off the, into recovery, or that path to recovery? And, when you expand your QRT, you really have to think differently, and what Will said couldn't be more, you're establishing who you are in the community with every interaction. Like say they were in Walnut Hills at a church, at a food distribution, and they're one person at a time. They're making those connections, building those relationships. That is huge. And you and I've had these discussions, but one of the things when we brought on all of our people in-house was we talked about data is people, and these people are struggling. So it's balancing that, getting the Narcan out, getting the hygiene kits out, and, doing your thing and documenting it properly. And, having a good software helps to document your successes. So thank you, Cordata. But, these are people. And there's a lot of different things that we do. And luckily, there's hundreds and hundreds of success stories like Will was just talking about.
Travis, do you want to jump in?
Yeah, I'll jump in. I think that data analysis is undisputably very, very, very important, right? Because the one thing, whoever's funding something, whether it's local government, state, federal, or whatever, is how much is this going to cost, and what's my return on investment, right? And I do, and for years in public safety, we've always been poised with the question, well, how much does the fire department cost? And we look at things that the property value that we save versus the property value that's lost. And I think when it comes to dealing with humans, we can look at it the same way too. And we have for quite a while. For example, if EMS resuscitates someone who's 66 years old from cardiac arrest and they walk out of the hospital, we proud that as 66 years of life that we saved. Our services, community paramedicine and quick response wise are the same. The success story about the gentleman that the chief described that's getting ready to get married and is getting a job, you've got to find a way to articulate that into economics, that you've got someone now that is not depending on the system. They're not going to the hospital uninsured, the cost to the healthcare system. They're not using public services that come with the cost and things like that. And that's a success story that I think you have to kind of tag some economics to. And individually, somebody may look at that and be like, well, that's just, that's good, but when you end up with a portfolio of that, and you can associate not only cost, but people that are going to contribute to society and things like that, then I think you get some data and you make a case for that. Fire prevention's kind of been like that. We've struggled with that for years. And the question always is, well, how do you know how many deaths you've truly prevented, or how much property have you saved with doing code enforcement and things like that? And what we know is trends, right? And things like that. So I think that is important here, and it needs to be coupled with individual stories, and we need to be able to associate a return on investment for those monies, regardless of who's funding it.
You kind of bring up an interesting point that you're contributing. Tom talked about that too. Like, the work you all do is contributing to a bigger trend. You're contributing to preventing overdose deaths, so you're contributing to preventing relapses or helping people get connected to treatment. But there are a lot of other factors that are kind of in that, and understanding success and your environment. Talk about the other pieces of information that you need. Like, what data do you look at to understand kind of what's going on and understand whether things are moving in the right and wrong directions? And what do you not have that you would love to be able to get your hands on?
Oh, let me jump on that one, Kelly.
Jump, Will, jump.
you and I have had that conversation. So
I know.
So we evaluate a lot of the data that I mentioned previously, number of contacts, face-to-face communications, number of connections to treatment, number, like I said, number of fentanyl test strips, naloxone kits distributed. But we also trend from our EMS database. We also trend our overdose responses, and the connections that are made through our 911 calls, because that's a huge piece. And that's the good thing about running the program locally. It's kind of our own data. We don't have to worry about the jurisdictional boundaries in trying to get data. So we look at the days of contact, we look at all that information to determine our efficacy. What's really missing is trying to track individuals once we get them into treatment, right? We've discussed that before. That's one piece of data that we'd really like to have. We know that we make a connection, that's great, that's a win, but we also know that the likeliness is that they're going to come out of treatment before they get back in. And so tracking that in and out and tracking individuals is very difficult, because that's, when we talk about success, if I had to paint a picture of what success looks like, it extends through treatment, it extends into successful reintegration into society, right? And reestablishing a sense of self-worth for these individuals post-recovery. We know that if there's a life waiting for them post-recovery, and they can get a head start with jobs, with careers, with families, there's hopes of getting children back. I mean, that's what drives these individuals who are suffering from this horrible disease day to day. And so that's ultimate success. If we can get them back to where they were before, get them reintegrated, that's success. But that would be a great metric. And unfortunately, it's one that we can't get.
Kelly, I think mine differs a little bit from Will. So I have two things that, and that's when we had the Norwood QRT, it was all right there. Now with the countywide QRT, we're servicing 44 agencies, police agencies, and I think fire's about the same, a couple less fire departments because they cover multiple jurisdictions. But getting those referrals timely, we were able to develop a relationship with Cincinnati Fire where we have a live dashboard where we're getting those overdoses live. We don't have that with every jurisdiction. We passed a law enforcement protocol back in 2015 mandating the reporting before the Good Samaritan law went in. So my one wish would be to be able to have those dashboards where we got the live overdose data as it was coming in. And then the second part, the hardest thing with QRT has always been to find people. We've used some resources with our fusion center to use criminal analysts to help us, but it's still difficult, when they are moving. And, we're trying to beat that. Like yesterday, we were at the Anna Louise Inn, trying to make those relationships and the transient people try to build that, but improving our finding people that have overdosed and then also trying to make sure we capture all that overdose data is huge.
It's kind of an interesting difference. Will wants to know more on the back end, and you really are thinking about how do we find the universe of people that needs our help. I think Tom's frozen again, but he looks like he's thinking intensely, doesn't he? We can tease him about this later. Travis, how about you?
Yeah, absolutely. Health information exchange. When we reach the point at which all services, all providers, anything to do, patient treatment, support, anything like that, can get their information into a health information exchange and people can access it, that'll be a huge step. And that's an incredible challenge. I do know that in Virginia, we're working very diligent to create a state health information exchange that is part of kind of a national interest too. But I think that is the number one challenge that we're faced with is, number one, knowing about our folks that we're working with and where they've come from and some details about them, because a lot of them aren't good historians and for a variety of reasons. The other thing that we want to know is not just where they come from, but we want to know outcomes, that when they leave us, what ultimately happens to them, where we can go and we can follow them for the next couple years or whatever, and we can kind of get closure to that, because that's important too. in showing a return on investment. When we can go in and we can look at patients, consumers, whatever, and we can go 3 years out, 5 years out, or whatever, and we can show that we were important in, you know, their outcome, then that's data that we want too. And it also allows us to learn what we're doing is working, or maybe what we're doing is not quite as effective as we thought or would like for it to be.
So it's interesting. You've mentioned this a couple times, Travis, and I think this is an interesting thought, is like, how do we look at the financial value of what we're doing? It feels like a sticky place to start to say that, because we are talking about human lives, but I think we've all acknowledged that this is first and foremost about doing the right thing for people. But also, when you're making a case for this, it's really helpful to understand the financial value. I'm kind of curious, because we got a lot of people on this webinar. I'm curious to know if anybody in the audience of the webinar has done that kind of work. And if you have, drop a note in the chat box, because we might ask you to share a little bit either during or after. But I'm just curious to know if anybody has done that kind of work. Will, have y'all done that?
Yeah, I mean, I guess to a degree we have.
Okay.
I mean, but I mean, that's a great point and a great space to explore.
Okay. So, and by the way, those of you in the audience, we're watching the chat and we're going to come back to a lot of your questions, but this one is kind of right on topic. So, you know, speaking of money and financial investment, where does your budget come from? You've talked a little bit about funders and getting funding. Where do you find funding? Where do you get funding? And what does sustainability look like for this work?
Well, when we first started, there was no funding model for quick response team at all. So we funded ourselves out of our operational budgets from both the police and fire. But, you know, as our program began to see some quick success, it began to gather some attention. And so, again, we've been blessed since the first couple of years of our program to be funded by a couple of different sources, but most recently and currently by the Ohio Attorney General's grant. And that is also augmented by local funding and donations that we received from in-kind support, which is another valuable piece to this whole thing, is partnerships. We talk about the necessary partnerships to make a program like Quick Response Teams possible. These things wouldn't be possible without that funding. And so we develop these partnerships. We welcome people on board to understand you know, what it is that we're doing. Our faith-based communities have been extremely supportive in our efforts in terms of donating funding for certain aspects that are not covered by the Ohio Attorney General's office, like housing for those that are exiting treatment. So partnerships like that are very huge. So we have those different types of funding sources.
Kelly, I'm going to stay off the video since I froze, if that's okay. So our main funding comes from COSAP grants. We have two separate COSAP grants. One is the state issued that pays for our African American male outreach program and one of our teams. And then we have the biggest grant is this COSAP that the Hamilton County Addiction Response Coalition receives. We also receive support from the Healing Communities study out of Ohio State through UC. We receive a lot of money from OCJS, or the Office of Criminal Justice Services, through DPS in Ohio, through JAG grants, through Recovery Ohio funding. So there's a lot of different funding mechanisms out there to sustain yourself and to get your program what you need. You know, like Will said, you got to have those relationships. You have to have you know, the equipment to get out there in the field, but there's plenty of sources of funding out there.
We're going to quote you on that, everybody. Tom says there's plenty of money. Call Tom. You heard it. You heard it here. We got you on record even, Tom. Travis, how about you?
Yeah, you know, I think you know, you can springboard a program with seed money. That's the easy part, right? Sustainability is kind of the holy grail of any service, and that's what you look to. And I don't think there's any one single funding source. You know, programs are typically funded by grant, through a healthcare system, or through state or local government. Those are kind of the three funnels. With regards to the healthcare system, though, I think that it's got to be articulated to them that the program's saving them upstream cost, even for the insured. And I think you want to put yourself in a position to be able to sit at the table with the insurance companies, whether they're brokered Medicaid or you're dealing with the private payers, and be able to articulate to them that you're saving them money and make the case for that's substantiated by data that you're saving them money, and you're in a position to be able to ask for some, and we should. Likewise, that'll serve you just as well for grant justification. And then I think when it comes to the local government funding, I don't mean this bad, but I think we have to out-compete with our competitors in funding, because there's only the fiscal budget, at least in Virginia, I can't imagine it's different in any other state, is required by law to be balanced for every government. So there's a finite amount of funds, and you've got to be highly competitive for those funds. And I think you've got to be able to come to the table and say, particularly in a situation, say homeless per se, do you want to open a homeless shelter, solve the problem for one day, and recruit twice as many people to come to the city because they hear that there's housing there? Or do you want to give our program some money to help address the individuals in the city and solve their problem without creating a funnel to draw more in to further multiply the problem? So I think those kind of discussions, and I think you've got to be kind of savvy to compete for your funds, to be able to articulate a good return on investment, but also a solution to the problem, and not just, prolonging the inevitable.
It's sort of an interesting challenge for you guys, because you talked earlier in the beginning about building collaborations, right? Building collaborations with housing providers and treatment providers and other folks in the community. But then you're also, you have to compete with those same people sometimes for funding. So how do you balance that, the desire to collaborate with these other systems, but also the just, this is the way funding works, the need to say like, hey, you should fund me instead of them because blah, blah, blah.
Right. And I'll tell you, I deal with that every day in a variety of aspects. And the thing is, you have to be trusted, right? They've got to trust you that if I'm the homeless silo and I don't necessarily get my funds, but I hear, the fire department got some funds for effort with working with people to find housing or whatever. Even though you didn't get your funds, I'm going to help you, and we're going to work together on this. It might not be the ideal scenario for them, but at the table of collaboration, you've got to be the type of person that people are willing to sit down with. And although it may not go their way, they do want to come back and have another conversation with you or do further business. And it just can't be, you can't just grab the money and run per se.
Well, Tom, do you have thoughts on that? Have you run into that in your own experiences?
Well, Kelly, I'll just add, and Dennis Lowe, my buddy's on this call too. And on the task force commander side, so much has been said in Ohio that you either get on the train of if there's more to being a law enforcement leader, and if you want funding, you better start doing more than just enforcement. There's more than just putting bad guys in jail. Some of these outreach programs, and QRT is one of them that is funded, but people that aren't, some of the traditional thinking, and you change thoughts with funding, right? That's a really easy way to make people think differently is by, if you want this X amount of dollars that you're used to getting for your task force, you need to do different things. So we've kind of had that forced on us here in Ohio.
Will, any thoughts?
Yeah, I don't really have anything
Okay.
above and beyond that. It was
I
well said.
Okay, I'm gonna pull in my colleague from West Virginia, Connie Pretty. Connie sent me a note and said that they have done some cost analysis on their program. So, Connie, will you tell me a little bit about what you guys did that was a cost analysis, and how did you do that? How did you pull that off?
So one of the things that we do is we utilize EMS data for the quick response team. So we are very lucky because we developed in 2014, prior to even getting the quick response team from these wonderful guys here on your call. We had developed a drop-down box in our EMS charting that said suspected overdose. So it was really objective criteria to find out how many overdose calls we were running. We didn't have to go into the chart and read the narrative or anything like that. So it was just a data point. So one of the things that we had done, we tracked them and we saw them going up and up and up to a point where we realized what a significant problem we were having. But that also enabled us to watch them go down. So after the quick response team started going out that first full year, actually we were about a quarter or two into it and we saw them trending down, and I thought, I'm afraid to say anything, I'll jinx us if I say anything. So we waited a while before we made any type of a public statement on it. But by the end of that year, we had seen over 700 less ambulance calls. Now, I'll say one thing and then I'll explain the financial side of it. We work with a researcher, Dr. Manny from Marshall Public Health Department. And I looked at him and I said, so we just reach a tipping point in this epidemic? Like so many epidemics, you just go up and up and up and then you reach this sort of tipping point. And he said, no, Connie, there are two things that affect an epidemic. And he said, that is intervention and death. And he said, we applied an intervention that has had a significant impact. As a matter of fact, he just sent me his first draft of his research publication that he's going to submit about the QRTs and their really effectiveness for reducing overdoses. So I'll send you a copy of that once he gets it all finished. But so we felt really confident that at least part of this was due to the quick response team. So what I did was that first year I went back in, and what we said was at about $500 an ambulance call, which generally speaking, everyone on this call knows that a lot of those calls are not reimbursed. The individuals they're not even eligible for state funded insurance. So it's just as a 911 system, we just, of course, absorb that cost, but it's $500 a call and over 700 less calls. Then one of the cost analysis we did was that we saved probably about $370,000 in that first year. Now that doesn't count what police and fire saved or the ER saved or just the value to life, and that is why we all do it. But, when I put that number out, especially when I do it for first responders, because that's sort of my background, that gets people's attention. So
Thanks, Connie. That's really helpful. So, it doesn't have to be the most complicated all-in cost analysis. You can start to sort of pull some information and patch it together. Thanks for sharing that. And we will look for, I love a research publication. So share that, please. We'll look for that. That's awesome. So we're getting to the top of the hour. I want to make sure that we have time for some of the questions that are in here. Let me look and go back to the chat. I've been kind of keeping track with a few of them. And again, if something pops up with you that you want to make sure that we talk about, let's do that. So one of the questions here was, is there any specific training for the QRT or for your programs? Do you have any different training or required training?
Yeah, so when we looked at first throwing our firefighters and medics and law enforcement officers into the street doing this kind of work, we realized that there was different skill sets involved with this. From a paramedic perspective, and I can let perhaps Tom talk a little bit more about the PD perspective, but from the paramedic perspective, we had to think more about holistic health assessment, the biopsychosocial assessment, if you will, as opposed to just the acute illness or injury. So we weren't there to just evaluate someone's health from, what's bothering you right now. It was, hey, how's your health look in general? And so we had to learn that type of assessment. We had to learn case management to a degree because we weren't used to doing that. So there was some self-defense piece to this as well. We realized that we were throwing paramedics into a situation where they're not summoned, right, by 911. And so as we branch out into a non-emergency response model, we wanted to make sure that paramedics were at least, we had law enforcement there for safety, but we wanted to make sure that our paramedics had some self-defense, in that regard. So, and in knock on wood, and I'm very pleased to say that in the 6 years now that we've been doing this, we've not encountered one violent patient, but that's part of the process. The other thing that we've done above and beyond their regular scope of practice training is embed our police officers and paramedics into the world of addiction a little bit more by putting them through the 40 hours of Cdca training, chemical dependency counselor assistant training. And the goal there is not to make them full-fledged CDCAs, right? The goal there was to provide them background knowledge of what addiction really is, to give them more of a language set to use. So they're a more integral part of the team. So in other words, when our community health coordinator, now Rachel, who's doing our follow-ups and providing the social services necessary for recovery, we also now have a paramedic who is on board with the language and what she's trying to do and what she's trying to accomplish. And what we found is that it made for a more cohesive team. When our paramedics can talk the language and they know what the overall objectives are, and they know where Rachel's going with conversation, they can help support that. And so instead of just being two pillars that are sitting in a room, they can all play an active role then. So there's just some of the steps we took from a training perspective.
Kelly, I'll add to that we did also, and I did it myself several years back, took the Cdca, and all of our officers are Cdca. They're all also have CIT training. I guess from my perspective as both a QRT officer and as a manager, you have to find that right person. This is not one size fits all. You have to have the right officer. You have to have the right paramedic and the peer. They have to understand their role, that the whole mission, which our mission is to connect people to treatment. So one of the things when we just set up our two full-time teams, one of the biggest training parts that we did is tours of our facilities here in Hamilton County. You have to have relationships where you get the express lane into treatment. We only have two basic detox facilities, in-house detox facilities. So it was really important for them to have those relationships, because relationships with wins, in these games. So I would say that and just the providers, knowing the providers as well as getting the right people in the right place is huge.
Travis, do you have anything to add on training?
No, I'll just jump in there and echo everything that they said. So EMS kind of has evolved from a truly emergency kind of a DoorDash delivery of life-saving services to now has really kind of become in the fire service, we would call it all hazards, but in EMS, in medicine, kind of a very broad service. And the scope of practice and some of the training standards haven't really kept up with that. And if you talk to the people who are really on the front end, understanding the EMS 2050 agenda and everything like that, in 5 years, EMS is going to look significantly different than it does today. And what that means is that the training and the education is really going to have to ramp up. You know, the thing about nursing, if you go to nursing school, those students, those nursing graduates, they get some developmental psych, they get some other classes and things like that. You know, unless you're going to paramedic school for 4 years, even the 2-year associate's program is just a touch of psych, you know, and things like that. And those are things that are important when it comes to interacting with someone and communicating with them, even writing. A lot of our narratives should be social work type narratives and not EMS, you know, standardized patient report type writing. And that's just not delivered. And what I think is that speaks to whatever the specific needs are in your community, those service providers there should have some expanded training based on that. We're in the process of putting 100% of our fire department through the 40-hour CIT class. Are they all eat up with it? And would you all want them out here doing it? And the answer to that's no. But what it does is it opens 100% of their eyes to the value in it. And if we say that 100% of the fire department is responsible for some effort in fire prevention, then we're going to say the same thing too about community paramedicine and supporting those challenges that our community has when they have the opportunity to. It's not that they're tasked with it every day, but they interact with the public at the grocery store, at the gym, working out, you know, and on calls. We want to maximize their opportunity to do that.
You know, it's interesting. So you guys have mentioned a number of kind of like existing trainings that a lot of folks in the field probably know about, like CIT, crisis intervention training. It's really interesting to use it with fire. I like that. That's smart. You've talked about the Cdca training. So there's a lot of things existing, but then you make an interesting point about just the education that we get in our fields and thinking about how you might make that different. So it sounds like there's a lot of places where our training and education systems are going to have to catch up to our new ways of doing business here.
If I could jump in there real quick, I'm Chris.
Yeah.
The only thing that I would like to add to that is, you know, as a former chief officer, before I retired, we have to be careful when we force programs like this onto our folks, especially in a fire department or a fire-based EMS system. I think anybody that works in a fire base, I just saw a little smile on Will's face there. You know, we don't always get to go put fire out. I often told the people in my roster where I just retired from, you know, we could probably be a volunteer fire department overnight, but those 8,000 EMS calls, they're not going to go away. So EMS is what drives the business. I agree 100% that the face of EMS is changing. I'm out of retirement. I'm the mobile integrated health captain now for a countywide system here in rural East Central Ohio. And, you know, the things that I do on a day in and day out basis, the 4 home visits that I made yesterday, quite frankly, an LSW would make in Franklin County. That's just the way it would work in Franklin County. There would be an agency with an LSW, but we don't have those resources out here in what we call God's country. So the only thing that I would caution, especially fire-based EMS systems, is we have to make sure, again, every organization needs people that can go into an attic and put a fire out. Every organization needs ceiling pullers and door kickers. And then every organization needs those compassionate caregivers that understand the science of addiction. And they are, I would venture to say, almost 100% of the time, not the same individuals. So you have to make sure that your organization is ready for what you put onto them and that you have buy-in from the people that you're going to ask to do it, because this is something that you cannot force upon people, because the client, the patient, the demographic of the person that we're going to try to help needs compassionate caregivers not somebody that's put on a truck that day because they got TT'd from another station and they have to do the work. This has to be somebody that wants to help people and has no stigma attached to SUDs. So those
This
just my 2
is,
cents worth.
I think this is a really interesting point, and I'm curious to hear how. I mean, Tom, you kind of hinted at that when you talked about finding the right people, right? You find the right people. I'm curious to hear how you guys have dealt with that. Like, first of all, how you deal with the resistance, right, and keep things moving, but then also acknowledge the differences in roles and styles that people have.
Well, Kelly, and I'll just say that, education of the leadership of that agency is huge, of knowing what type of officer you need. I mean, we had a state trooper on our team. State troopers traditionally are auto accident and, traffic citations. So luckily we got a veteran and they were very understanding of our needs, and we got a heck of a good state trooper that gets it. That also, you can't forget too, people that are affected by addiction have a lot more interest in participating and helping, and everybody in our team has been affected by addiction, including myself and my family. So that is huge. And, some of the better officers I have found that working on QRT are the ones that have been in an investigative assignment where they have to talk to people and they have to listen to people, because that's just as much, the solution is listening as much as talking. So the investigators really work the best in this field.
Travis, I saw you jump on mute. I know you want to jump in here. I can see it.
No, I think that Chief, and I'm going to try to get this right here, Minipace that just went, absolutely hits the nail on the head. Without any doubt, this is not just any kind of work that you can come out and tell people they've got to do. In fact, I would be willing to take that further and say that if you're and my department we were a contemporary fire department, all hazards and everything. And you start integrating these other non-emergency services, also what we call value-added services, things that are not essential service lines. It's a change, and people either subscribe to that or they're not sure, or it's not part of my job. And he's absolutely right. And I think it goes beyond just your selection process and your promotion process for this new service line, because that's what you're doing, is you're creating a new service line within an organization. We've got emergency responses that are divvied up into fire, EMS, tech rescue, hazmat type thing. And then you have this community risk reduction side. And within that, then you've kind of got this value added services of, some social work and things like that, and looking at data and everything. You got to have the right people in there, but I also think you have to prepare your organization to understand that. One of the quick things that happened when we started doing community paramedicine was the guys in the station call them frequent flyers. I like to call them frequent service users. They started, gladly reporting these. The person working the case would go out and talk to them. And then the next day, the guys in the field are screaming that, what's going on here? Why didn't you went out there and talked to them? Why didn't you fix this? And I think the organization has to understand, and this service line has to have a mission statement of its own, right? I mean, it's got to have a mission. It fits into the department, but you have to know what the mission of this service line and this program is. But I think the chief, and he's speaking from experience because he's seen it, he's absolutely correct that this is not a job that just anybody can do. The other thing is people who are capable and people who are engaged. There is a burnout rate with this. This is not simple. You go out here, you put a car fire out, pack the hose up, and you're done. A lot of this is case management, emotional attachment, fatigue, tracking this down. Everything leads to a dead end. I'm not bringing any resolve. I'm getting a lot of pressure about this type thing. And it's hard on the folks that work this. And that has to be recognized, that maybe there has to be a cycle on, cycle off for some of our folks to ensure longevity in their tenure.
I want to give Dan Malloy a chance to jump in here. He is off camera and he's muted, but I know him well enough to know that he's like pounding his fist, wanting to jump in on this topic because this is a passion of his.
No, I appreciate it, and I thank everybody today. Of course, I know Will and Tom very well, and you know they're definitely leaders, and their experience is powerful. And Connie, thank you for what you do, and also the fact of the matter is, Chief's great to meet you. I haven't had a chance to do that yet, but the question is so spot on, and these were conversations that the Chief and I had very early on because we didn't have any model to work from, and we knew we had to change organizational culture as well as community culture. So what are we going to do? We had to start. You said it, that communication within the organization, within the community, talking about and learning about what those feelings were. Did people feel the same way as us? What were their expectations of us? Were the expectations that we don't even spend time worrying about it? Or the feeling is, do we need to do something about it, as was said earlier? And the decision was made, we need to coach them up. We need to spend time as leaders integrating and having conversations at those roll calls and those briefings and those dailies, and then demonstrating that we were working slowly but listening. And Will was very adamant to his EMS folks that we're not going to tell you to do anything. We're going to provide you with resources and ask you to participate, and you choose to do what you choose to do, and then slowly build culture. And we always talked about letting the wins demonstrate themselves, letting the wins take a chance to create storytellers and provide internal champions. And we had some successes very early on with people that walked several miles to get to the fire station and happened to hug one of the most persons in the fire station that was against the work that we were doing. And then he slowly became a storyteller and a champion as he realized that we're talking about people and influencing the lives and the benefits of the families, and just realizing that to a point in time where he said, hey, boss, can these resource packets that we're handing out on these runs, can we just get the hard copy at the station so we don't have to ask to make copies? We'll just make them as we need them. And we knew we were slowly winning that culture over, but it was a process of education internally as well as externally. The big thing that I think we learned is, you're always going to have the 20% that say, yeah, sure, whatever you need, boss. The 20% will never support it, and the 60% in the middle that are going to determine based on situation, time, sleep, attitude, whole 9 yards, whether this is worth their effort. But what we didn't expect is the number of folks that worked across our agencies, not just police and fire, but parks and roads and all these different agencies that make up a community, that were impacted by the disease of addiction, that came forward and presented themselves and said, my loved one, my family member, my fill in the blank, and how can I help you? Can I be a part of this? Can I help and serve on a volunteer basis at one of your events? We just found, again, internally within our organizations as well as externally, the communities did some of the same things. We had families traveling from well outside of our region because we were somebody that was doing something that they were willing to help for. So they were willing to drive from Indiana, drive from Kentucky to come to our town, to be there with us, to stand up with us and help tell the story. So we slowly, it was a slow process. It was slower than what we wanted to have. Like Will said, it was 9 months. It was closer to 14 months. It took us a long time to move through the bureaucracy and the politics of this conversation within a lot of different communities to get these things done. But we had wins along the way that made us believe that we weren't crazy. We had people like Tom Fallon to say, hey, tell us what you're doing. We had Chief Simmons in Troy, Ohio that said, tell us what you're doing. So we felt like we were on a path, but we didn't know what the hell we were doing. He's exactly right. But we figured, if we're going to go, we're going to go down burning, and we're going to go down trying. And what's the worst thing going to happen? We pick it up, we learn from what we mistake, we come back together, and we figure out what to do next forward. So we learned along the way, really worked hard on the communication piece, worked hard on listening and paying attention, being respectful. If we tell you to do it, you'll do it once. If you learn over time that it's the right thing to do, it'll integrate, and you'll tell that story and you'll share it amongst your fellow firefighters, your fellow police officers, and we will have excitement around the saves and excitement around the impact we're having. So but you can't you're absolutely right, Chief. You cannot tell anyone to do this because they have to understand the value, because we learned it very early on. Officer calls off sick, we just put an officer in there, and at the end of the day, I was like, that officer's never doing this again. But we didn't know that. We were rookies, and we just tossed it out with our partners. Nan and our partners said, hey, he's a nice guy, but he don't get it. Well, you know what? Thank you for your service, but you're never doing this again. We had more education to do along the way. So, it's powerful work, and it definitely makes an impact. And we, to Kelly's point, what defines success? I always used to say it's a smile and a hug. You get a hug from a family member, a thank you. I know that you can't quantify that, and I know you can't take that to the board, and you can't grant writers all that, but that's really all it took for me to know that our impact was real. And you start saving lives, and people just say, how can I help? What can I do to be a part of it? And then you just grow from there. So I appreciate your time. Thank you for allowing me 2 seconds here to speak. And
thanks, Dan.
I appreciate
But
it.
we could come up with a hug tracking system. I'm kind of not not averse to that. So I want to ask a few forward-facing questions, and actually, this one just came up in the chat. That's kind of right. We are of one mind, Brian. So how do you suggest, how do we change the perception, right? Looking forward, I think I hear a group of people that's passionate about this and thinks this is the right thing to do. But how do we change the perception that this never changes, that you can't help, that people with addiction won't get better? How do you make that culture shift towards hope, right, and prevention, away from this constant death and overdose and problem after problem?
If I could, one of the things that we try to do at our organization, and that the organization that I'm currently working at, we're going to roll out, is we're going to bring in success stories. I can stand up there in my uniform as a chief officer and tell everybody how great this is. I can bring an LISW in to do it. I can bring somebody from a detox center in to do it. But what we really need to do is we really need to get in front of our crews, get inside of our civic organizations, go to city council meetings, village council meetings, township council meetings, go to your larger employers in the community, all of your stakeholders, and you literally take with you somebody that is in recovery. It doesn't even have to be long-term recovery, but somebody that's in recovery and that has signed off and signed all the appropriate paperwork. But when you show the video of them being transported from the lobby of your firehouse because they walked in and they said, "Hey man, I need treatment today. I'm tired of chasing it." And you take their personal use level of product, you discard it, you treat them like they're human, you give them a peanut butter sandwich, a glass of water, you find a detox, you get them in a detox, and you show the video of what they looked like while they were in the throes of addiction. And then they're standing there 90, 180, 1 year later, a completely different person. And that person tells you, listen, the very simple fact that man or that woman gave me a peanut butter sandwich, gave me a pair of socks, treated me like I was a human being. When people start hearing that, they start realizing, holy crap, that I'm guilty of stigma. And especially in the business where we're at, law enforcement, fire, and EMS, we stigmatize with the best of them because that's all we ever see. So we first have to look inward and be willing to make that open and honest assessment. And then the next thing we do is we reach out to our community stakeholders that may be tainted with stigma, and we invite them to open their mind and just show them, listen, this is a success story made possible by giving somebody a chance because of a follow-up or because of a walk-in or what have you. But I think you just flat out put it in their face and you show them success, and that's how you get buy-in. So
sharing our successes. We did talk about training and things. Anything else that you guys can think of to sort of help us shift that culture?
Kelly, I'll just add the leadership in your community. I mean, we are blessed in Hamilton County to have Denise Driehaus that, I mean, within a month of us starting our quick response team, she was out in the field with us and she saw, and we actually the day she was with the very first day. She's been with us several times, but we were invited into the engagement center the very first day she rose. So that is huge. If you don't have, you have to have that leadership buy-in, whether it's city council, whether it's county commissioners, whatever your form of leadership is there, because that goes hand in hand with sharing your successes. You know, we have the advantage of being in a metro area and being able to go on the news and talk about our successes, and we do that, but it's a lot more. You know, you can talk about your successes, but if you don't have the buy-in and a champion in an elected position, you're kind of you're just swimming.
All right, last question before we wrap up here, and it's a little bit of a double-barreled question, but conceptually, can we do this with other problems? Is this an approach, or is this a model that can be applied to, you know, we talk a lot about addiction, we've talked about mental health issues, but is this something we could use to solve other problems? And then, you know, from that, what's next? Like, what does the future look like for you in 3 years, 5 years? And Travis, I'm going to ask you to go first.
Yeah, so I think absolutely this approach could be used to solve any problem. I think there's two things that's important. Collaboration, and whatever problem you're developing, an advisory group, board, someone to figure out how to solve it. On that group, there absolutely needs to be a survivor of the problem that you're trying to solve. And that's become a national theme with so many things, is having someone who's lived that and experienced that to be able to say that this is what works. I get this. The other thing it does is in communities and settings where police and fire and other government healthcare services may not be trusted, that survivor is trusted amongst the most, who are the most fearful of the subject. So it gets you in, and it helps you with that. For our department and 5 years down the road, sustainability and continuing to, we typically operate about 5 years out anyway, with planning and being able to project what costs are going to be and everything like that. And our 5 year out is looking at what the needs are of the community and how the community will evolve. And the mission may be a little different or may change, but also who's going to pay for it and where's the money coming from. And that is a daily challenge. That's a financial sustainability is 1 FTE. If you want that, somebody could literally spend 40 hours a week going to meetings, selling the program, searching and things like that. And we capitalize on that in several areas. Thank you.
Hey, Will, how about you? Could we use this for other things? And what's the future?
Yeah, absolutely we can. I think it's a model that can be applied to the scope of any social service, really. And to a degree, we've kind of done that here at Colerain, and partnering with Hamilton County Public Health. We've put into effect our first community health coordinator, and that individual is responsible for taking referrals from our police department and our fire department and following up with individuals that have been categorized as somebody who's needing some help, whether those are environmental services around the home, whether those are addiction services, whether those are basic needs, food, clothing, whether those are veterans who need services. And so that same individual's following up with these individuals, as does the QRT. So I think, you know, the possibilities for such a response model are pretty endless. Public safety, you know, as we work together with law enforcement, we encounter a lot of the same individuals. And so as we're being problem solvers in our community, it makes sense to use both of those services together to address some of these social needs. As you know, as far as the future holds here, you know, we look at expanding the success and the scope of what we can do in that realm. But then also, we really want to dig in a little bit more into our data. We've not done a super job in looking at data. You know, or collecting, I guess I should say. I mean, it's difficult, right? And so we want to get a little better at that, tracking demographic specific data to monitor trends. But we want to be more in the realm of education and getting into getting into schools and having a model that is 360 degree, right? Not just providing referrals and resource allocation, but to get in front of a lot of these different things.
And Tom, last but not least, could we do this for other stuff? And what does the future look like?
Well, Kelly, I'm going to turn it around on you and ask you the question, because I'm not actually, but you think about when the whole theme of QRT is how can we help you? Why wouldn't it work for other programs? And whether you, like Will said, whether you're talking about veterans, whether you're talking about homelessness, whatever the case may be, whether it's law enforcement led, fire led, civilian led, it doesn't matter. It works when your opening line is, how can we help you? Which is, that is our theme. And, doesn't matter what your problem is, because people, I think time has proven that there's going to be a new evolving problem, and what is next. And those guys that know the answer are making the big bucks, not us, right?
We may know more than we think we do, you guys. But at least I think you know more than you realize you do. That is, we are at time. So that's it for today. That's it for the conversation. I want to say thank you so much, Will, Travis, Tom. Thank you for giving us your brains for a little bit and for the conversation. I just want to drive home this: relationships matter and our stories matter. And it sounds like this is a place where you can start. It's okay to start small and just let it grow. But if you're listening to the people you're working with and you're responding to what they need, you're probably going to see something that's valuable to the community and to the people you're working with. So I want to say thank you guys for being here. Thanks for sharing kind of the journey of this. We have recorded this, so for those of you who are here, we will make a copy of that available to you all this afternoon, or later, probably later this afternoon. And if you have questions or need anything, please don't hesitate to reach out. If you want to connect to one another, ask more questions or have more dialogue, we're happy to help make that happen. So thank you guys and have a great afternoon.